Okay, welcome everyone. Glad to have you with our webinar. It is a pleasure to be here. My name is Tim Erickson. My colleague Donnell Harvin will be joining us, and appreciate Amani Altel's contribution as well as Leo Sino. They'll be involved as well as Krilio Kalutkok, giving us a perspective from Ukraine. So I'm going to start by sharing my screen, if I may. Let's see how this goes. Can you see that slide? Amani, Leah, can you see the slide?
Yes.
Yeah, we see.
Thank you. All right. We're going to just give a couple more minutes for people to join on. It's 2 minutes after the hour, and we want to respect your time. Amani, Leah, how many participants do we have right now?
We're at 29 right now.
29. Okay. We'll give it 1 more minute and then we'll get started. Again, thanks everyone for joining on time. We really appreciate it. Okay, well, welcome to the webinar, Harvard Humanitarian Initiative, Ukraine CBRNe Preparedness for Healthcare and Public Health, CBRNe Implications in Humanitarian Conflict Settings. And for those of you who don't know, I know this is a very educated, well-informed audience. In case you're new to the topic, CBRNe stands for Chemical, Biological, Radiological, Nuclear, and a very important part, particularly with the Ukraine conflict, explosives, because so much of this has been traumatic, traditional warfare with blasts and burns. So we think the E on CBRNe is important to include. Our agenda today, we are going to welcome and introduce with some opening remarks. We're going to give you an overview of Harvard Humanitarian Initiative CBRNe work in Ukraine. And these are opinions and experiences that both Dr. Harvin and I have gone through over the past 3 years in Ukraine during the current conflict. They don't necessarily reflect the stances and viewpoints of Harvard University or HHI. So I want to make that disclaimer on behalf of those presenting today. We're going to look at the impact and ongoing work in Ukraine, as well as CBRNe preparedness response, a scoping review, some research that we're doing, and then really expand it to CBRNe in austere, low resource and humanitarian environments. We see that on this call, we have about 75 participants from 25 different countries, which is just remarkable. So we're all tuned in to learn about CBRNe and discuss CBRNe from the Ukraine case study, but we also want to make sure it is very important we talk about the global impact of CBRNe and the threats globally in low resourced areas. We're going to make sure there's a Q&A interactive audience roundtable, and then of course some closing remarks. So we'll adhere to the time. Since this is a webinar, you may be muted, but we encourage you to use the chat actively. In fact, we encourage you to put in who you are, where you're from in the chat so we can look at that as well as your comments. Near the end, we will open up the microphones so you can actually speak and other participants can hear you, and our list of panelists and members of the panel can actually respond to you real time. That's the beauty of a webinar. So with welcome and introductions, if you wouldn't mind, again, putting in the chat where you're from and your name, and we want to get a good feel for it. We have people from all over the world, from Oceania, Australia, New Zealand, from Southeast Asia, from China, from India. I see we have participants from Northern Africa, from Sub-Sahara Africa, from the Middle East, certainly Ukraine, but also Eastern Europe and Western Europe. We even have participants from Iceland, one of my favorite countries. And then, of course, participants from Canada, North America, Central America, the Caribbean, and our neighbors to the South and South America. So this is truly a global program, and we welcome everyone here to put in your remarks, and we really want to hear from you. And there's going to be some polling questions throughout, which you can answer, and it'll help us guide the discussion and also where we want to go in the future. So our work in Ukraine has been ongoing. Personally, I've been going back and forth in Ukraine since post-Chernobyl in the early 90s, working with environmental issues, security issues, post-Chernobyl studies in survivors of Chernobyl, the children, the liquidators, but it has really scaled up recently since 2014, quite frankly, following the illegal annexation of Crimea and East Ukraine, and then, of course, with the recent 2022 Russian invasion of Ukraine, the HHI team has been going into Ukraine for several deployments, which you will soon learn about. Our team is not just CBRN. We've been going in and leading trauma initiations. Dr. Sean Kevelhen has been our project lead. We are also doing pre-hospital, nursing, pediatrics, mass casualty events, and it's been a real team effort. So CBRN, chemical, biological, nuclear, radiologic, and explosives, has been a part of this much bigger project that's focusing on trauma response in Ukraine during the war. So these colleagues have been very instrumental in moving this forward. So this isn't just about myself and Dr. Harvard. I won't bore you with details, but the chart is this again. There's a lot of people involved, and most importantly, the involvement, it has been our Ukrainian colleagues. They've been so instrumental in helping us move this initiative forward. So why is CBRN important? A lot of people say, well, with the Ukraine-Russian conflict, it's traditional warfare. There's a lot of blasts and burns, but is chemical, biologic, radiologic, nuclear also an important component of it? We think yes. Maybe it's not being used on a daily basis, but the threat is always there. And the threat has increased since Ukraine has entered Russian soil. And it's been clear that Russian leadership is saying they will use whatever means are necessary to move the war forward. And because of that, we feel historically and present day that CBRN remains a very important threat, and not just in Ukraine and the current conflict, but with bordering countries and those throughout the world in low resource setting. Vladimir Putin himself has warned us that Russia is ready for nuclear war if necessary, whether it's all-out nuclear war or strategic nuclear war. And certainly, as you know, there's nuclear power plants in Ukraine. Zaporizhia is the largest in Europe. That has been under threat. So the nuclear radiologic potential is very real, as well as the chemical and the biologic. Also, CBRN has been in modern warfare with our experience in Syria. Syria saw the illegal use of chemicals such as sarin and chlorine gas, and there was interaction with some of the Russian government military. So the threat of bringing this to the Ukraine war was certainly on our radar and the world's radar. So Syria, we've learned a lot from it. If we have Syrian colleagues on the call, highly respect you, what you've gone through. We'd like to get your input on what's going on in your area of the world. But a lot of what we saw in the Syrian conflict made us aware that CBRN attacks could happen anywhere in the world, and particularly in the Russian-Ukraine conflict. So our mission was to develop CBRN training for civilian medical workers, first responders, and other key personnel. We wanted to focus on those frontline workers. We're very motivated to translate our training into Ukrainian, and we had some wonderful colleagues on both sides in the US and in Ukraine helping us do that. We wanted to conduct TTT courses, which is our train the trainer. Our goal was to work ourselves out of a job, to go in, train, equip, do it all in Ukrainian, and then turn the courses over to our Ukrainian colleagues to train their own, and then become a center of excellence throughout Europe. Purchasing equipment was a challenge, not only during the war, but during the COVID pandemic, as supplies were limited, and shipping them to Ukraine became quite a challenge. We'll talk about that more. And then we wanted to deploy to Ukraine and deliver all the training. We wanted this in person, and a lot of you work globally, and you know, in this age of webinars and Zoom and emails and phone calls, WhatsApp, that's an important line of communication, but there's nothing quite like meeting person to person, face to face, building trust, building sustainability. And one of the many reasons we keep going back is to build that trust and build these programs. And of course, safety was important for our Ukrainian colleagues who are putting themselves in harm's way by coming to these training courses, and our group to get back. And we did have security, excellent security through International Medical Corps with border crossings, evacuation plans. And I can't say enough good things about how IMC help move this project forward as well. So here are the areas where we've been going to Ukraine over the past 3 years now. And you can see many of the countries, major cities have been involved. The West, even though that's been less of a conflict threat, there have been bombings and threats in Lviv, the largest city in the West. Ternopil is a major university setting. Certainly Kyiv, the capital city, the crown jewel of Ukraine, has been under fire, and many of our trainings have rotated around the capital city. Kharkiv, which has been under fire because it borders so close to Russian and East Ukraine militarized zone. Dnipro, which is along the river and now has become more of a frontline area. We've done many trainings there, and we have amazing colleagues in Dnipro, and right below it to the south is Zaporizhia, where the nuclear power plant is, and certainly one of the epicenters of threats for not just chemical and biological, but certainly radiologic and nuclear. And then the pearl of the Black Sea, Odessa, has been under fire because of the access to the Black Sea to the rest of the world, with access for grain exportation, as well as coming and going, and the environmental impact in Odessa and the surrounding Black Sea area. Kherson is a good example of that, has really been under scrutiny. And then the bordering countries, as you see, from Moldova to Romania to Poland to Belarus, they're all involved, all vulnerable in this war. So we learned some complexities and lessons. We had to translate everything into Ukrainian. Many people did speak Russian, but it was our Ukrainian counterparts who wanted this all in Ukrainian. And yet, if someone was uncomfortable with Ukrainian, we did not turn them away. Sometimes they were better able to express themselves in Russian. We tried to be inclusive and neutral in that regard. But really, our goal was to get this all in Ukrainian. Getting equipment and supplies into Ukraine was a challenge, particularly getting to cities like Kyiv, Dnipro, Zaporizhzhia, Odessa, Kharkiv, which were under fire, and supply chains were low, not just in Ukraine, but surrounding areas. And then evacuation plans were super important, and dual use facilities. And what we mean by this is some of the antidotes that are used in CBRN events like atropine, auto injectors, naloxone, potassium iodide. Those types of things can have dual use for good and nefarious reasons. So it was harder to transport these. And our instructors, hard to recruit during a war. There's a lot of burnout. There's a lot of concern about their jobs, their family, their safety. And many of them came from parts of Ukraine that were under fire, like Mariupol and some of the east parts of Ukraine. And so they had post-traumatic stress disorder. We had to be very sensitive to that. And then just getting our trainers and students and instructors off from their jobs to engage in these training activities was super important. So at this point, we're going to talk about some of the equipment we had. And I'm just seeing, is Dr. Harvard on the call?
No, Tim, not yet.
Okay, so I will continue on. And Donnell, if you're on, feel free to chime in, but I'm going to continue rolling with the program. So, and again, if you're joining us after the introduction, please use the chat to introduce yourself, where you're from. You'll be muted at this point, but following the presentation, we want an open discussion and want to hear from you. And in the meantime, if you have questions, please put them in the chat as well. We want to make sure this is an interactive webinar and not just me talking. So great to have you all from, again, as I said at the outset, we have over 75 participants from 25 different countries. Our case study is focusing on Ukraine, and yet we really want to put forward other areas that are vulnerable. Currently, the Middle East, for sure, with Lebanon and Gaza and the Israeli conflict. So there's a lot going on in the world, but Ukraine is our focus right now. But I think we can learn a lot from what we've experienced in Ukraine. So the equipment itself was pretty low budget. As you know, in CBRN, if you've done CBRN training in the United States or UK with FEMA and some of the other larger organizations, WHO, NATO, the equipment is very expensive. Decon chambers can be 50 to 100K US dollars. The antidotes are in short supply and very expensive. Proper PPE, personal protective equipment, is in short supply, and things like gas masks. Very important in training, but also super important for a real event. Here are some of the other equipment we used. Rather than bringing in very expensive decon chambers, we used really pretty low budget and portable shower decon units, gas masks, which were meant for training and not the real event of a chemical, biologic, or nuclear event. And yet many of our participants wanted to keep the mask because they said they had nothing else to protect themselves in a real event. But we tried to make the training equipment realistic and foolproof, but with multiple training sessions, equipment wore down and had to be replaced. And fortunately, our Ukrainian colleagues have been great in resupplying this for the training, but we do need more equipment, which is something we'll talk about later in the webinar. During a war, not surprisingly, there are bombings and active bombings. Now you have a training at a hospital, at a major hotel, at a university, and when the air raid sirens go off, which they often do in Ukraine until they can pinpoint where the missiles are going and being targeted, many of our sessions required us to evacuate to bomb shelters. We thought that it would stop the training, but because of the resilience of our Ukrainian colleagues, they wanted to continue. So a lot of our trainings were in bomb shelters during the time in conflict. Fortunately, most of these people were very safe and we were able to return to the training centers, but we always had to be very vigilant because it's easy to get fatigued with the number of air raid sirens and alerts, but you have to be vigilant because, as you know, even recently in the past few days, there have been many victims injured and killed in Ukraine with the continued bombings, whether they're missile guided or drone technology. Here is our colleagues. This is Dr. Gonzalez Marquez, Catalina, who continues teaching. And as you can see, we had real-time Ukrainian translation. Our goal was to turn this all over to the Ukrainians. And once we had these trainings without needing translation, as you can imagine, they were done much more efficiently and in a quicker fashion. We tried to make the drills and the breakout sessions very interactive. It wasn't enough just to give a basic lecture and have them sitting in a chair all day. We made sure people got up, active, hands-on, enforcing learning points. And the participants acted as rescuers, but also as patients to give this idea of a large amount of patients and victims coming at you. It's a very important part of our trainings. So they got used to deconning, PPE, and also transporting patients to higher levels of care. They were rescue, security, and also hospital-based. And oftentimes there was low lighting. We made sure there was no electricity, no running water to make it very realistic. And we did a lot of trainings outdoors, even when it was cold and rainy, because that is more of a real scenario in a real conflict setting. Again, we had equipment, we had masks, we had PPE, but as you know, in conflict, sometimes you don't have a running water supply. You may not have all the buzzers and bells we have in the US and throughout Europe. So we also had to teach not just decon with water supplies, but dry decon. What if you don't have a water supply? Or what if it's in January and it's below 0 Celsius or Fahrenheit and you can't expose a victim because they will succumb to cold injury? So how do you dry decon was a very important part of this. Also, what happens if there's a radiologic injury? How to use the radiologic monitors for making sure the decon was complete was very, very important. And we also looked at new innovations. This is Dr. Harvin modeling this. We had a Stop the Bleed program, which was highly successful. We had so many volunteers coming in to take this. This is a tourniquet application to prevent hemorrhage from a limb. And with our CBRN, we said it's not enough to focus on chemical, biologic, nuclear, radiologic. You have to focus on real-time conventional warfare, bombs, missiles, blasts, burns, and on top of it, could there be a contaminated wound with a chemical, a biological, or radiologic component? Once we started incorporating trauma into our CBRN trainings, it really took off and the numbers grew vastly. And to the credit of our Ukrainian colleagues, they said it was much more realistic that we brought in the warfare part. So since May of 22, when we started going over there, we've had 1,500 CBRN participants, and that's growing thanks to our master trainers. And we'll talk about our master trainers very shortly here. Our Train the Trainers, well over 100. These are the finest participants who became trainers. We've been training classes. We publish, which I'll talk about in a little bit, as well as the conferences. So This has been a labor of love to make this happen in Ukraine, but also involve our Ukrainian colleagues at every step of the way. And one of the best things we've done as a group, and this was with an agreement with YouTube, Leah and Eric Gorelnik, many people on our team developed videos, all in Ukrainian, 2 to 3 minute videos, which highlighted the CBRNe trauma, nursing, pediatric, pre-hospital, mass casualty disasters, very succinct videos, which could be accessed all over Ukraine, even in remote settings. So we're very proud of those. And these readiness videos have really literally gone viral. We've had nearly 1 million hits from Ukrainian cities. And in the CBRNe realm, things like how to use an auto injector. How do you administer naloxone if it's a weaponized opioid? How do you decon? All these things are available in very succinct fashion. So here are some of the links, and we can provide these for lay people as well as professional healthcare workers in CBRNe readiness. So we've been really proud of that, and it's been a highly successful program. Without boring you, I'll tell you that we have been publishing. It's very important to put this in the academic literature. It's not enough to say you've gone in and trained people and it went well. You really need to document. And our M&E and our evaluation team has been extraordinary to look at, did our trainings really make a difference? Was there an increase in knowledge? And was that knowledge used in a practical setting, and was it sustained? So it's very important to document this in the literature. We're one of the first to do that in a war setting, where we actually evaluated our effectiveness. And if we weren't effective, we were trying to change it and be better real time. So it's important to publish. And one thing I want to point out, we didn't just go in and data grab, as many researchers from the US have been accused of. Every one of our articles has Ukrainian authors. We thought that was vitally important, that we're doing this together as a team. So the publications I'm showing you, here's using a basic frontline emergency care course with Sean Kevelhan, his first author in BAJ. Open, again, Ukrainian authors. Every time we wrote, we included. There's works in JAMA, conflict and health, disaster medicine. So we thought it was vital to keep the publications going, as well as the training, as well as the funding, as well as the sustainability, the involvement of our Ukrainian colleagues, and bringing them in to the academic side of things. And they have a sense of pride and ownership that this is their project. It's not ours. So this was very important to us in a team approach. So now I think I am right on time. I want to turn it over to my dear colleague, Dr. Krylyo Klupkuk, who is in Ukraine now. And Krylyo is one of he was a student way back in 2022, summer of 22. He was so extraordinary with his field knowledge, emergency care, knowledge of CBRNe, that he became an instructor. And then he went on to teach several courses after he took our train the trainer. And not only did he instruct, he told us what needed to be done, what needed to be changed, what we could do to make it better, more realistic, what equipment we needed. And then he went on to become a master trainer and a master instructor. And these are the best of the best. Right now, as we speak, we have master instructors giving CBRNe courses all over Ukraine. In fact, we just had a large group in Dnipro. And it's because of our master instructors embracing this course, giving it in Ukrainian, is why it's been so successful, and we're very proud of it. So we're really pleased that Krylyo is able to be here, and he's going to share with us some of his reflections on CBRNe training, the practicality, and in classic Krylyo fashion, he's going to tell us, how can we improve? How can we be better in the current conflict? So I'm going to turn it over to you, and I'm going to mute myself. You've heard enough from me. and we'll go from there.
Thanks, Tim. Hello to everyone. I'm Kirilo, and I told my story. My journey began in September 2022 when I became a participant in a series of trauma course organized by HHI and IMC. For me, it was a way to shift my focus from concerns about the situation around me to friendly environment of learning something new and engaging in discussions with my international colleagues about the difference in our medical fields around the world. Later, I complete TOT course and start assisting with a station and lectures. Then was a situation where course planned in Zaporizhia for 2 weeks, but due to security reasons, they were split between two cities, and courses running simultaneously in Dnipro and Zaporizhia. And then I became the first national instructor of CBRNe at the first phase of training. Now I'm master instructor of this course. I'm grateful to many people who helped me along my way. I had the chance to study with Tim, Donnell, and other professionals who provided outstanding mentorship. This team include individuals with extensive experience in various areas of CBRN, such as BAM technicians, toxicologists, biologists, and other specialists who contribute to my growth as a master instructor. I always had the expert support which helped me to solve issues I encountered during my studies. Overall, also helped me to expand my knowledge and fill gaps, build my experience as an instructor. I would also like emphasize our course concept, which bring participants together with diverse backgrounds. We had some highly specialized experts local in CBRN who served as our local experts during the course, and they still feel valued during the course. Before this training started in Ukraine, this kind of information was only accessible to very narrow field of specialists like firefighters, nuclear industry workers. And when regular hospital workers or average person attended the course, they often had a significant gap of understanding topics. We explained how they should behave and general concepts of CBRN scenarios. A majority of people were surprised to learn that incidents are not only about nuclear power plants and weapons. These situations we can encounter in many places around us. As Tim said, we trained around 1.5 thousand participants, and now we have a pool of 11 master instructor from this pool. My favorite part of the course is radiation module. We had Chernobyl explosion in my country. My mother was a liquidator of the Chernobyl disaster, and many our citizens think nuclear danger comes only from power plants. In the course, we discussed nuclear source that are more closer than they expect. Our course has its own relevance and importance for participants. They find answers for their questions, fill knowledge gaps, and learn general rules for situation and actions they should avoid. What's great that we don't just discuss concepts. We demonstrate them as much as possible. As Tim told before, like when we talk about gas masks, hazmat suits, PPE, participants can put them on. If we talk about wet decontamination, we rinse water on them. It's not just words like do it this way and that way. When it comes to the nuclear module, we explain invisibility, and they experience it through UV contrast powder to understand that radiation is truly invisible. This hands-on approach helps them understand and course context, because we deal with a layer of complex information. As Tim told, from my perspective, from my opinion, I have some things how we can, for example, improve this course. First, it's really would be nice if we will have real CBRNe equipment for master instructor courses. It would be beneficial to have actual equipment to demonstrate the difference, for example, between certified B class suits and COVID hazmats. Instructors could wear this equipment to share real experience and insight. And second things, it's legal framework integration. We need legal adjustments to enable to use of certain materials within our country. Like, for example, EMS service here not allowed to enter red zone. Currently, we have a working group developing local SOPs, which will eventually be integrated into our national healthcare system, and it will be useful. Thanks for your attention, Tim.
Julio, that is excellent. And I know it is heartfelt. You have been with us since the beginning. You continue to be a leader and a difference maker in the field. We thank you for your dedication. You have put you and your family, your friends in harm's way to do these trainings. And because of you and the master instructors and all the participants, it has really become the program that it is. And it was always our goal, as Donnell Harvin often says, work ourselves out of a job. And it's people that like you, leaders like you, that are moving this forward. And our goal, of course, is for peace in Ukraine, and that a CBRN event would never happen. But as the war goes on, we also realize you and your colleagues are now going to be experts, not only in Ukraine, but throughout Central Europe, all over Europe, as an example for other areas that are vulnerable to CBRN events, particularly in low resource humanitarian settings, which we're going to talk about. So thank you for that. It was engaging, and thank you for the examples and the equipment. Yes, we want to talk about that, how we can deliver on equipment and make the trainings more sustainable. So thank you again. And I see my colleague, Dr. Donnell Harvin, is on. Donnell, can I turn it over to you for the next segment? You're going to talk about some of the scoping research we're doing. And if you have the slides, you can share. Otherwise, I can pull up the PDF here.
No, I'm good. Thanks. And thanks, Tim, for helping me out. Everyone's great to see you. I wish I could have joined you a little earlier, but I had some major technical issues that we're trying to overcome here. And so let's get into an evolution. So we've gone through this morning the work that we're doing currently in Ukraine, and kind of the testimonial that you heard from our colleague who's actually in Ukraine right now. You know, the work that we've done over the last 2 years has kind of prompted us from a research standpoint to kind of look at not just operational issues that CBRN has, but really organizational issues. And in doing so, and Tim went over some of the publications, what we found was a paucity of publications specifically for CBRN that relates to the civilian environment. If you did just a quick literature review, you'll find there is a dearth of knowledge for CBRN in the military space. And that's because CBRN was originally created as a battlefield weapon. But as we've gone so far past the World War Is and the World War IIs and the Cold War, what we find is that CBRN is a threat for, is a concern for violent non-state actors and rogue nations. And that really places it squarely in the realm of the civilians, particularly the health and medical industry. And so our colleague, Anna, who cannot be with us today, has launched on a very a robust research project with myself and Tim and some of our other colleagues to look at some really overarching questions. And these questions are: how well are healthcare systems, facilities, and individual providers, how well prepared are they to respond to a CBRN? If you look at many of our countries, there is a robust CBRN capability for healthcare response, but many of the capabilities reside within the respective Department of Defense or Ministry of Defense, and they may be forward deployed. What happens if CBRN is used in a civilian environment? Or what happens if those casualties, those soldier casualties, are brought to a civilian hospital for treatment and care? What are the main barriers and challenges to effective training and preparedness for healthcare workers and first responders? And what are the best practices for CBRN preparedness? And really, what we're looking to get at the end of this research project is a compendium of best practices and produce model protocols, SOPs, and objectives for preparing civilian medical authorities and medical workers and humanitarian organizations for dealing with and preparing for CBRN. And here are some of the very high overarching objectives that we've kind of looked at over the last year since we've started researching this. We're conducting an assessment of preparedness to evaluate the readiness of healthcare systems. Once again, this is all based on civilian and humanitarian settings. Identification of gaps. What are the challenges and limitations that basically institutional level organizations face when looking at CBRN training, whether it's resources such as equipment, are there protocols? One of the things that we have a pretty good concept of in the United States is training. But the question's always asked, well, what protocols are you training to, right? And so it's one of those, what comes first, the chicken or the egg? Do you create the protocols and then do the training? Do you create the training and then kind of wrap around protocols to meet the needs of the responders and the equipment and the scenarios that you have? And in many of our research, we're finding that there may be training, but there's no protocols. Documentation of best practices, I mentioned that as well. Policy and protocol recommendations at a very high level. What are the policies that kind of permeate down to allow the people on the ground to actually be successful in a CBRN mission? And then global equity, which is something that we're always looking at across all the humanitarian space. And that's looking at disparities and preparedness between high income and low income countries. We found that's very important, and we're doing a full analysis on that. We'll talk a little bit about this a little bit further on in the webinar, but Tim and I and our team are incredibly concerned about low and medium income nations being able to prepare for a CBRN event in the civilian space. Now, we already talked about the Ministry of Defenses and the Department of Defenses having some type of robust capability that's not particularly transparent to us, right? A lot of that stuff is, secret or not available to civilians. The question is, what can civilians do to prepare themselves for either a CBRN event that impacts a civilian population or CBRN casualties that are brought to a civilian facility? This is just, not to get too nerdy, this is just some of the databases that we're looking for, and I'll explain to you why we're showing this to you in a few seconds. But once again, We've done, I think it's been about 5 or 6 months, Tim, really what I would consider an exhaustive search for information related to this topic. This is some of the preliminary work, some of the preliminary findings. Once again, we haven't drafted the paper fully. It's not ready for publication, but I wanted to put it out there because this is going to be part of the topic of our discussion as we do our roundtable. Global and very high level, kind of global context, what we're finding is that there's not much standardization in CBRN response protocols. There are some organizations that have some guidance documents, but in terms of really SOPs, operational level, very prescriptive documents, we're not finding much. What is out there is highly fragmented. It lacks coordination from different stakeholders, different government bodies. There's not international consensus nor coordination on preparedness and training. Integration into current medical systems is a challenge, particularly when you look at most health systems, even in the US, are so strained in terms of their resources that CBRN is really an esoteric or not even a tertiary, maybe a down the line, 10th order perhaps priority or not a priority at all. And so, because everyone figures that the national level government and the Ministry of Defenses have CBRN, so to speak. They have that in their portfolio, and they're going to come and assist the civilians. That may or may not be true, particularly in a conflict environment. There's not enough training and resources for individuals and to coalesce around. Once again, that goes back to the first one, which is the first bullet, which is lack of standardization. Is there an internationally recognized procedure for doing CBRN? Are there internationally recognized protocols or standardized procedures? And there's not much. At the health facilities level, we're finding, once again, this is all very preliminary, so we're not really ready to publish this. And part of this is for us to engage with you to kind of help us guide us through some of the things we're seeing, perhaps give us some context or some resources that we can look at. Disparities in preparedness and infrastructure amongst different in different contexts. Lack of funding for CBRN preparedness. I mentioned that before. It's not really a high priority for many organizations and for many civilian authorities. And at the individual level, there's very limited hands-on experience and training. One of the things that we found in Ukraine, and in using Ukraine as an example, is the fact that medical workers, we wanted to work with medical workers, we wanted to work with first responders and getting this information into their hands. But they're busy working, right? So how do you pull these very critical, essential workers out of a busy schedule to basically take them offline to do CBRN training? Or training in a topic that many may not see as important or priority. And so some of the current educational curriculum and training programs, some of the best practice we're finding is curriculum developed based on profile and the knowledge of the trainee. So really custom-made solutions. There's no one size fits all. That's what we've done over the last 2+ years with our colleagues in Ukraine. Tim and I went in there with really a malleable CBRN curriculum that we then turned over to our colleagues like Kirillo and asked them to help kind of reform that in a way that makes sense for Ukraine. And I think that's why it's so sustainable. It's so well received because it was really created in collaboration with our partners on the ground, and they have full ownership of that project now. They have full ownership of how it's taught, and they have the ability to reach back to subject matter experts at HHI or abroad, any of our colleagues that we've brought into country, and ask them for solutions for problems that we didn't envision when we first started this program over 2.5 years ago. Competency-based training approaches are being developed in response to existing needs. But once again, I do want to reiterate that CBRN has to be seen as a priority. Multiple training models, including simulation sessions. What we found is that organizations that have sim labs and some type of simulation type of construct do very well and exceed in CBRN training. We found that in US, we found that in our partners in Ukraine. A lot of the work we're doing right now is with universities and hospitals that have some type of simulation lab or simulation leadership structure that really allows them to think outside of the box. And I think that's a successful part of any CBRN program. And lastly, a hybrid structure of e-learning. When you're dealing with austere conflict environments, it's not always possible to get the subject matter experts or the trainers on the ground to work with the individuals that need that information. And so things like this webinar, things like what Tim and I have done over the last 2.5 years, which is deliver content remotely via e-learning, and even the things that we're developing right now in HHI, which is strictly a fully online CBRN training module, program, I think are part of a multi-layered solution to getting this knowledge into the hands of individuals that need it. The lead investigator, the primary investigator for this research is our colleague, Dr. Anna. She's also a DRPH candidate at the School of Public Health at Harvard. Here goes her contact information. If you have any resources, any information, databases, perhaps a published report that maybe we haven't found, we'd love to hear from you. You can contact Anna directly, or if you would like to collaborate with us, we would love to have collaborators as we look at creating some type of guidance that low and medium income countries that are experiencing humanitarian crises, war, conflict can use in order to prepare or respond to a CBRN event. I think we're going to hold on to questions to the end, right, Tim?
Yes, that's correct. Then I will open up the microphone for an interactive session. We
Great.
want to encourage that. But in the meantime, if you have a question, a comment, where you're from, please put it in the chat. I know Katie Murray is putting access to some of the articles we've talked about, as well as the research in progress. And just looking through the chat, Donnell, I see not only US colleagues, but we have colleagues from Brazil, Malaysia, Egypt, Canada, of course, Ukraine, and Iceland. So really good representation. So let us know where you're from. And we want to expand this beyond the case study of Ukraine and look at some of the more austere, low resource humanitarian communities. And Donnell, why don't you take that from that standpoint? And I see we're picturing Syria, which has been a case study that we've learned a lot from, and hopefully we have some Syrian colleagues online as well. Go ahead, Donnell.
Great, thank you. And so you've heard me talk and use this term a couple of times, and I want to just spend about 10 minutes providing some context to what we're talking about. I am classically trained from the operational level in CBRN. I started up my CBRN career as a first responder with the Fire Department of New York City. This goes back to in the 90s, and then started doing hospital preparedness for CBRN, training physicians, nurses, and paramedics, and then eventually ran the CBRN in New York City for the health department, specifically for biological and radiological response. And so throughout really, and then went to DC and did Washington, DC, our nation's capital, and did CBRN in forensics. And so throughout my entire CBRN career, I've had the luxury of having all the technology, all the expertise available to me, all the research, the laboratories. And then Tim and I went to Ukraine. And we were almost, really, Tim, right? Immediately stripped of a lot of the luxuries that we had because we couldn't import a lot of the technologies, the CBRN technologies, just something basic that we took advantage of, took for granted rather, CBRN mask. Because of international regulations that prohibit the movement or shipment of dual-use technologies under the ITAR regulations, which many of you may be familiar with. When Tim and I did our first mission in Ukraine, we weren't allowed to bring many of the CBRN equipment that we're normally used to. And you saw that in the slide that Tim presented, how we had to kind of degrade what our CBRN training equipment was and basically buy things off at Amazon. And so what we started, and that I'll be honest with you, that created some anxiety for me. But then as I spent more and more time, and I did multiple deployments in Ukraine, I started having this, aha moment, this kind of moment of clarity, and that we need to be able to do CBRN in an environment that is highly technical and allows us to have all the capabilities and all the research that we normally would have. But we need to be able to bookend that with being able to do CBRN in a very austere, low-tech, degraded environment, an environment you may find in conflict or war. And if we're successful in doing both of those, I think that's where the mission needs to go. Because you can always train people to a certain standard and let them go up. But if you train them here and they can't do this, it's very difficult for them to go down. And here I'm going to just share a few photos of some of the site visits and some of the work we've done with some of our colleagues in Ukraine. This is an actual hospital. Now, many of you may have been in the humanitarian space for some time. Maybe you worked at a hospital in a conflict zone. For me, it was shocking to have a civilian hospital that needed to be protected from bomb blast. And so, but it was also comforting when we got in the hospital and started doing work, and my colleague Katie was with me for this particular deployment and this training. And when we saw our colleagues using some of the same equipment, some of the same nomenclature that we would universally, like a triage tag. This is particular in Ukraine, this is a triage tag that had integrated with it CBRN. And we started over the time embracing this kind of low resource, austere CBRN environment, so much so that we're now looking to cater to that. This is one particular hospital. This is how they segregate or cohort green, yellow, and red tags. This is how one hospital, this is where they place their PPE that's used. They acknowledge that in Ukraine, the infrastructure is not 100% reliable because you may turn on the lights one day and the power is out because the electrical grid has been downed. You may not have water. How do you do decon if you don't have water? And so they're storing water in solutions. How do you charge up all the fancy CBRN detection equipment that you may have purchased that costs so much money if there's no power for 24, 48 hours? And so that's really the evolution of where we've come. And if we can do CBRN in an environment like this and embrace this, then I think we'll be successful across all regions. And that's really what we're focusing on in our future work. This is a decon shower, very rudimentary, but it works. And so once again, I'm just going over some of the kind of Spartan environments you'll find in conflict and war that we need to not run away from, that we need to embrace and acknowledge. I also think that it's important to acknowledge the fact that it's not just state actors, but it's also non-state actors, violent non-state actors that are potential risk for launching some type of CBRN event, either in a conflict setting or in a peacetime setting. Many of you may be familiar with UNITAD. That is the UN's investigative team to basically hold Daesh accountable for their war crimes. And in their report, I believe there's a 9th report out this year, but in the 8th report, they detailed in exhaustive terms how this terrorist group during the fall of Mosul took over a university, utilized the dual-use technology in the laboratories, in the bio and chemical lab, and created biological and chemical weapons, and then shared that information broadly with their network. There's physical evidence of the actual CBRNe agents. There's written evidence in terms of the documentation, and there's human evidence in terms of actual prisoners of war that were experimented on. And so there's no wonder why, after doing their own research and applying their own methods and spreading that information throughout their network, that we started seeing CBRNe plots linked to Daesh, from ricin to chemical improvised explosive devices and anthrax. And so this is really the world that we're facing now. You can be in a conflict or humanitarian scenario in which there's violent non-state actors operating near or around in the region, as well as state actors that may be maligned or rogue. I'm going to just show this video very briefly.
The sound of a child's cry, alive and being treated. After dozens of Syrians choked to death in a suspected poison gas attack on the rebel-held city of Douma. Activists say bombs fell in hospitals and shelters last night. Many of the dead and dying found crouched in basements.
Yeah, it's going well.
Douma is one of the last towns still controlled by rebels in the area. The Syrian government has attacked it for years and vowed to retake it. Were there many people hiding in the shelters there in Douma?
Some told us that they had been scared to come out of those shelters and that people had come out of the shelters and they'd been killed.
If it turns out that chemical weapons were used, President Trump will face a dilemma. Last April, he ordered cruise missile attacks against the Syrian military in retaliation for a sarin gas attack, but recently announced
So I showed that video, and I'll cut it short, and we can share the link here. It's clearly old. Many of you are already aware of the chemical agents that were used in Syria, but you may have not realized how embedded humanitarian workers were when that happened. I personally know several physicians that were there and really didn't understand what they were dealing with, and how this was used exclusively on a civilian population. And so the threat is real, and it is something that we're concerned with. And so, you know, Tim and I spent a lot of time with our colleague Sean, who's on the call, and Katie, and some of our other colleagues talking about how do we reimagine humanitarian disasters. And really acknowledge the fact that the use of CBRNe by a state or violent non-state actor is a legitimate concern in conflict settings. The potential for intentional or accidental release of CBRNe can create a humanitarian disaster on its own, or exacerbate an existing one, as it happened in Syria and so many other places we'll talk a little bit about later. And, you know, I think we acknowledge that humanitarian medical workers are not particularly well trained. And I think the research that Anna and our colleagues have done has borne that out. They're not well trained. They're not really particularly well equipped to protect themselves from CBRNe, let alone treat casualties. And that's really the state that we're at right now. With that, I'd like to turn it over to our colleague Leah to get us started on our Q&A session. And we're going to have plenty of time, I think we're right on time, to really engage with you. We don't want to talk to you. We wanted to really interact with you. And the presentations that you've heard heretofore really lay the groundwork for us to have a really good interactive session. So Leah, do you want to get us started?
Yeah, I can do that. Thank you, Tim and Danelle and Querido, for a great presentation. This is really great work that can show how we can also bring this outside Ukraine and make sure that healthcare workers and other frontline providers are trained in CBRNe, because this is happening all around the world. And what comes to my mind, and probably to a lot of the audience over here, is the current use of CBRNe weapons in Gaza and Lebanon by Israel. So this has been extensively documented over the past year since October 2023, but also in 2009. This is used in civilian areas that are heavily populated. And recently, actually 4 days ago, Human Rights Watch published a report talking about the extent and use of these chemical weapons by Israel in Lebanon and Gaza, the physical harm on the local population, but also the socioeconomic harm that this has caused to the local population because it has affected the environment in which they lived. So they had to be displaced, but it also affected their livelihoods because their agriculture land has also been damaged. So a really nice report to which I'll put the link in the chat, since it also includes testimonies from the ground. And I wanna, so this is like a comment and question, but I wanna throw it back to our experts and ask them how we can bring this work from Ukraine to other regions that are today affected by the use of these weapons, and how we can also hold state and non-state actors accountable for using these illegal weapons. So thank you. And I'll put the link in the chat to the report.
Yeah, thank you, Leah. This is an excellent comment and question. Donnell and I were very focused on making this about Ukraine, our experience in Ukraine and our dear colleagues there, but also to take this to other areas of conflict. And certainly all eyes are on Gaza and Lebanon and the use of chemical warfare, particularly white phosphorus, which we learned about from our Ukrainian colleagues. We came in with traditional CBRNe training, particularly in chemicals, sarin gas, chlorine gas, weaponized opioids. But it was our Ukrainian colleagues saying the Russians are using white phosphorus. Are you training us about how to respond to white phosphorus? We had heard about it as a toxicologist. I knew about it, but I had no idea. And so we pivoted and had a whole session and drill just on white phosphorus and some of the industrial chemicals that have been bombed used. Acids and alkalis are something that are used worldwide. So yes, we are concerned. We are shocked that it's being used, but not surprised because of the current conflict in the Middle East. We do want to bring this training beyond Ukraine, certainly to bordering countries of Ukraine, but to other areas. And also being culturally sensitive that just what we train in the US, the UK, and Ukraine may not be the same fit in Lebanon. We have to be culturally sensitive, we have to be language sensitive, and we also have to be sensitive to the safety of those that we train and the civilians that are caught in the crossfire. So this is an excellent point. Donnell, I'd be interested in your reflections, and then we want to open it up to other people about their area or region of the world. And I believe we also have some poll questions coming up. So Donnell, why don't you remark on Leah's comments, and then we'll make sure this is an open discussion with our other participants.
Yeah, I think that her comments are spot on. I also, as a self-professed CBRNe SME, I acknowledge the fact that when I think of CBRNe, I think of the traditional CBRNe, right? I don't think of weapons of war. And so in Tim, you just did a lecture on this last week, a presentation for our Ukrainian colleagues. It was never in our CBRNe training. It's not in traditional CBRNe training to look at white phosphorus because we never thought that would be used on civilians, right? And so now we really have to, once again, it's part of the reimagining what CBRNe looks like. I'll give you an example. Daesh created a weaponized version of nicotine in the University of Mosul, which is about estimated anywhere from 200 to 400 times more powerful than normal nicotine. And so you can imagine the type of impact from a toxicological standpoint that would have on the human body. Who would think of that? And so in civilian populations, they don't have PPE, they don't have masks, they don't have suits, they don't have the training. And so, and that was the, you know, the feedback we got from our Ukrainian partners. We don't know how to deal with this white phosphorus. It's just not part of your normal medical training. It's not part of the CBRN training. And so what do we do? So we need to, as an organization and as a community, be able to be more responsive to the individuals on the ground, the individuals in Gaza, the individuals in Lebanon that are who are our colleagues who are saying, we don't know how to manage these injuries. We've never seen this type of weapon used before. How do we save lives? Because at the end of the day, this is about saving lives and preventing injury, death, mortality, and morbidity. So one of the things that we're looking at, Tim, is evolving our program into more intermediate and advanced CBRN. We're embarking on that process now, and certainly, reimagining what weapons could be used in civilian space, particularly a densely packed space like Gaza. I think we didn't get a chance to talk about that, Leah. Some of these, some of these densely packed developing countries, low and medium income countries, we're talking about a density of 4 or 5 families maybe living in a flat that's 2 bedrooms, right? Like not really imaginable for many of us individuals, right? Entire generations living in one small structure, 3 or 4 generations rather. So that breeds a whole new area of blast, burn injury, epidemiology that we really haven't envisioned, because a lot of the research we've had in CBRN is based on the soldier, right? And the treatment that the soldier would get. And so with that, I think that, thank you for dropping that link. A very interesting report, nonpartisan, non-biased folks, Human Rights Watch, highly recommended. And thanks for helping kick off this segment of the question and answer. So I think we have a question we want to start off with, right? Amani, Leah, can we post that question now to get us started?
Yes. 1 second.
So we're going to ask you folks to do a quick poll. And we have the polling questions.
Yes, they're coming right up.
Great. And this is going to help not only with our discussion, but also with our ongoing research. So the first one is a real simple one. This is all anonymous, by the way, just so you know, we don't know who's answering this. What region do you feel is most vulnerable to a CBRN incident? And I'll make my selection. You can click on multiple answers, but I think we want, no more than 3.
So we have the Middle East coming in as the number 1 choice, Eastern Europe as the 2nd choice, and Central Asia as 3rd.
I see a hand raised.
Yes, I can let Budinga, I am going to unmute you if you want to ask a question.
Hello, good morning, good afternoon, good evening. Can you hear me?
Yes, we can hear you. Hi, welcome.
Great.
Thank you so much. So while the questions are going, I just wanted to introduce myself. My name is Dr. Boyika. I work for the International Organization for Migration, and I'm based in Dnipro in Ukraine. So thank you so much, Donnell, Timothy, and also to our speaker from Ukraine. It was really interesting for me, I believe. The first time I saw the title of the webinar, I was really interested to join. And thank you so much for presenting your findings. So first, I want to highlight some of the challenges which you've mentioned, which would be on the standardization of protocols for the training. I believe it is really important, and I look forward to working with IOM as well as other organizations to collaborate with you on how this can be better standardized. So 2 questions. The first would be, what were your reflections in terms of the community level participation? So now I'm looking towards the dimension of preparedness. So what was your reflection in terms of your interaction with the community, and what role do you believe or think we can use this training as a preparedness for the community? Secondly, is on the question of collaboration. I think I've seen the Harvard Humanitarian Initiative, and we also have WHO at the country level preparing trainings. We also have organizations like my own, which are delivering CBRN training. So how better do you believe that we can collaborate? To close that point, we do have the health cluster in Ukraine, which is coordinated by the health cluster coordinated by WHO. So how better do you think we can improve our collaboration so that we can have one training that can be simply streamlined across broader arrays of not just health professionals, but communities, displaced persons, as well as cross-country collaboration. Thank you so much, and I do hope my questions were clear. Over.
Thank you for your contribution, and I'll just I'll rephrase the two questions just to make sure we have it well. And I would invite my colleagues Carrillo and our other colleagues from HHI to join in. The first question is, what was the community reception to the CBRN training? How did the community respond to that? And I think myself, Tim, and Carrillo will have three different perspectives on that. And then the last one is, how can organizations like ours coordinate effectively with other authorities on the ground to not only promulgate some type of unity in terms of protocols and procedures or standard practices, but also coordinate in terms of knowledge sharing and our ability to kind of reach out across our respective constituencies and make sure that we have a unified front. Did I get that right?
Absolutely, Donald. Thank you.
Great. I'll give my perspective, having, I stepped foot in Ukraine, just 2.5 years ago for the first time. Tim will have a different perspective. He's been working with colleagues in Ukraine for decades, and obviously Kyrilla's on the ground. My perspective is I was really impressed with the reception particularly for CBRN. We never had empty spaces in our class. They were always overbooked. Often we would have to bring extra chairs. There was one course in a hospital that we taught in Dnipro where we told them we only had equipment and instructors for 25 students, and they filled the room with 50 physicians and nurses and medics, so much so that they were basically standing the entire day, and they never left and they never complained. This is knowledge and information that they long for, because they understand the risks that they face. They understand the context, I think, a lot better than many of us that are not on the ground there. I'll turn it over to Tim for his feedback on that.
Thank you, Donnell. Yeah, I echo that. I've always been impressed with the community outreach over the many years I've been going to Ukraine. The resilience, the unification to be this all together, whether it's a Chernobyl disaster or warfare. In this particular project, when we started phase 1 in 2022, we thought it'd be frontline workers, healthcare workers, maybe a hospital administrator. But if you look at some of our data, 40%, almost half, were non-medical, non-health. They were security, police, school teachers, metro workers in Kyiv, which, as you know, when there's a bomb scare, people go to the deepest metro system in the world, Kyiv. And the metro workers wanted to know, how do we evacuate people? How do we recognize chemicals? What do we do if we have to decon deep into the metro system? So rather than saying, whoa, this is not what we expected, we embraced it. The community embraced it. We made sure we taught it at all levels, because you had some that were neurosurgeons, some that were radiologic engineers with PhDs, and then you have a police officer. They're all part of the community. And where they really came together, we found, was with Stop the Bleed, application of tourniquets to hemorrhaging limbs to save lives. Even those that had less medical knowledge felt that they could really help and save a life. That springboard into us really starting to define who are going to be the trainers, where are we going to do, to your point, Bonilla, to unify this so there isn't several factions teaching CBRN with different manuals, but coming together with a unified standard operating procedure. And that's our next phase, to work with hospitals, major medical centers, universities, and centers of excellence in making sure people approach it the same way. Always keeping in mind, though, you have to be malleable. You may not have the equipment, you may not have the weather, you may not have the safety to evacuate, but the basics of CBRN should be consistent throughout. We shouldn't be competing, we should be coagulating, as it were, and collaborating. So this is such an excellent question. I could talk about this all day, but the resilience in the community of the Ukrainian people is inspiring. And I know our Ukrainian colleagues are getting weary. It's been a long process since 2022, since 2014, and yet they're still there. They're showing up. As Donnell said, we never turned anyone away. They came early, they stayed late, they went to bomb shelters to continue this learning because they really felt they could help their country and their people by having this knowledge. So excellent question. And Krilo, you want to comment on that as well, about making it standard as far as the teaching across Ukraine?
Yes, a bit about participants. Also, same as you told, because I travel with this course in different corners of our country. In every city, it was course, let's say, like full of students and different field of medicine, different general field of participants, and everybody have a questions because information is specific. And after course, they fill these gaps. And this part, which I like, that we wish in the end of every course that we wish you never faced with this problem. But at least in case of emergency, you have a knowledge how survive. Because it's really a question of surviving. And also another part, it's like if you, for example, have fanciest equipment, but you have no idea how to use it. We also describe that this you can use, this you cannot use, like this stories about the real CBRN cases where our instructors and colleagues have super low resources. And yeah, course is standardized. We have already created list for stations, for lectures. So really, course is absolutely same for Zaporizhia, for like Kiev, Odessa. Now is standardized.
And I think the second question was how we can collaborate. And I think, a webinar, this is one of the impetuses behind the webinar. Tim and I and our colleagues are sitting here and many times and saying, we wish we can reach out to an international community and basically create, a community of interest around CBRN for civilians like us, right? Because we're told that our respective Ministry of Defenses or Department of Defenses, they have it, right? They have CBRN, but they have CBRN for their environment, for their context. And it's clear that in the work that we've done in talking to other collaborators, really we've traveled the globe over the last 2 years in presenting our work in Ukraine, that many civilians such as us lack that knowledge. And so things like this, we'll share our contact information if anyone wants to collaborate. And specifically, Bodinga, we'd love to contact you, especially if you're on the ground in Ukraine. We'll connect you with Kirilo and we can start a dialogue to try to find out how we can collaborate. And not just, once again, using Ukraine as a test bed, as a case study, but taking those lessons learned and really expanding into other regions. So thank you for your question. I think we'd like to move on to the second question now, if we can. And once again, we're hoping these questions can spur some discussion. But if you also have a question or comment that has nothing to do with the questions that we're going to be showing you in a second, please raise your hand and we'll address that. So can we move on to the question number 2, please?
Yes, already up.
I don't see it on my end. That's fine.
We have the answers came in here.
Tim, can you see the second question?
No, I cannot.
Danelle, if you click on polls and quizzes and then scroll down, do you see that 70% almost participated?
I don't see the polls and quizzes icon. Maybe you can guide me to that.
Maybe what we can do is read the question and then just explain the results.
Yeah, I was hoping you could read the question because I can't see it.
So we have question number 2 is rank in order the items that the international community can best assist countries experiencing humanitarian crises in achieving optimal CBRNe preparedness.
Great. Thank you so much. If anyone's had any issue seeing that, just let us know. Once again, I think this is a great conversation to use for further research and delivery of things like this, but also to spur some discussion. I see someone. Is there a way we can provide a link?
Yeah, sure. 1 second.
Right.
And while we're doing that, maybe we can take another hand or question from the
Sure.
chat.
Yeah, I do see one hand raised, so I'm gonna let Huda in.
Hi, Huda. Thanks for
Yes.
participating. Please identify where you're from and your question and comment.
Yes,
Thank you.
yeah. My name is Hudanan. I work at the Eastern Mediterranean Regional Office, but I'm participating here not by my professional work, but my personal interest in the topic. So, because you already mentioned the white phosphorus stuff, so I can share with you the country experience because I was in Gaza at some time in my life, and I remember the use of the white phosphorus for the first time back in 2008, 2009 war. People were directly hit by that, and they were severely burned, and they were suffocating by the gases produced by that white phosphorus. And it was a shock also for healthcare workers because they did not see this before, and people did not know how to manage all of that. So they started to consult with people who might help in that regard, and they started to do awareness for the people about getting away of that, not to inhale the gases, to use wet towels if they are in an incident where the white phosphorus happen and it's dropped in their homes, and also to try to turn off the fire using sand, not water. So it took a while until people became aware about that. But unfortunately now we are seeing heavier use of these types of weapons, and I wish that there were more efforts to protect the civilians from that, and to enhance the awareness of them too. But protection is the first thing that should be done, and this is really a very, very bad experience that I've seen, and I wish that will end actually. No one in the world will witness that again. Thank you.
Wow, thank you, Huda, for that account. Yes, it has been documented that white phosphorus was used in Gaza in 2009 in particular. And we've had documentation, and I know we have colleagues from Dnipro on the call, of white phosphorus use at Menshnikov Hospital, where uncharacteristically burned wounds, open wounds, continue to smoke or smolder even days after the soldiers or civilians present. And it does take a different approach to protect patients, civilians from the burns because they can be deep and continual, and how you evacuate patients and decontaminate them is different. It's a different approach. And because of the burning effects of phosphorus, you have to cut off oxygen supply, which promotes the burning. So you have to irrigate and even submerge these wounds to stop that oxidation process. So it's different. And when you don't have the equipment or the resource or the knowledge, it's going to be even more confusing. So we're convinced this is happening. It's well documented, as Leah said, and it is documented in Ukraine. So this is a real issue, and we know it's occurring. Now, something has to be done about it. One is knowledge and treatment and prevention and evacuation, but the other is to, again, make it clear by international law, this is an illegal act. This is a war crime to be using this. Some military outposts say that white phosphorus is not a chemical. It's just part of a military defense system, a smoke screen. It's not true. It is a chemical reaction. Oxygen and phosphorus is chemicals. So this is a banned substance that should not be used anywhere in the world.
Yeah, and I think, and just add briefly on that, one of the things that humanitarian and medical workers can do is to properly document its use and report it, right? Because often it's these individuals who are on the front lines that are in the that have the ability to shout up and allow the international community to be aware of what's going on. To Tim's point, we didn't know about the white phosphorus in Ukraine until I think we were in Dnipro, or I forgot where we were, Tim, when it first became an issue. And that's because our medical workers that we work with, our colleagues, were saying, hey, how do we deal with this white phosphorus? And I'm like, what white phosphorus? They're using white phosphorus, and they had photos and documentation. And so, properly documenting these injuries, showing that, through the differential diagnosis process, that it could be nothing but white phosphorus, and sharing that with the international community, aid organizations, humanitarian organizations, and human rights organizations, I think is key. I just want to mention something about the second question. I know this is a question that we had, and we keep on saying, we're using Ukraine as a case study. In the second question, there's a couple of answers that specifically speak to Ukraine. I would ask you just to think more generically. So where it says train Ukrainians in CBRN, you should think, train the medical community, train humanitarian workers, not just Ukrainians, as well as the almost the last option, bring international awareness to CBRN gaps in Ukraine. I would, make that to your region or globally. And so we don't have time to amend those questions on the fly, but that's just something that I picked up because this is, we're trying to stay consistent with the data we collect. And these are questions we've asked other international partners that we've had the opportunity to talk with, like we're having here. So I think we're going to move on to and I don't see any hands. Is there a hand up? And if so or not, let's move on so we can move through these questions. We're doing really good with time. Let's move to the third question. If we can display that. If you can't see that question, there's a link for the questions in the chat. And the third question is, what are the major CBRN risks or threats that your region faces now and in the future? And this may take a few more minutes. This is a free form text, so we ask you to type it out. If possible, keep the answers brief. So once again, from a data collection standpoint, it goes a long way when we're able to kind of analyze this type of qualitative data if it's shorter. And this is something that I'll throw to one of my colleagues. I like this question a lot. Carrillo, could you answer this question for us? what major CBRN risk or threat do you think Ukraine faces now and in the future?
It's difficult to predict because we have in parallel using of CBRN, and we have, for example, still have power plant, and it's like two parallel things, which one is already happened and another it could happen in future. So difficult to clear answer.
You know, one of the things that I've talked about extensively with my classes is the potential for some type of industrial accident, whether it be a chemical or nuclear power plant or even a biological research that, you know, whether it be accidental or intentional, that could lead to a release. I don't think we've seen that in modern time. Last I think we saw was well, I mean, we can go Chernobyl, we can go Bhopal, right, in India, and we can go Fukushima. And we see the impacts that has. We also see the lack of preparedness for the surrounding community, right? So that's a pure CBRN, right? And this is one of the reasons why to just, you know, give or assume that the Ministry of Defense or you know, some high level government has the ability to respond to CBRN and not really prepare the civilian level, I think is a mistake. Certainly, many countries have a construct where military assists in civilian disasters, but you really have to assume that there's some lead time involved there, right? So, you know, 24, 48, quite possibly 72 hours, you know, the civilian are going to be on their own, I think, if something like that happens, some major industrial related disaster that releases CBRN. And so this is what we're trying to do. We're trying to have this discussion, raise some awareness, and kind of draw up some consensus of how medical workers will respond to something like that.
Yeah, absolutely, Donnell. And certainly in East Ukraine, it's a heavily industrialized area. So there could be intentional bombings of, say, an ammonia plant or some other chemical plant. That's a distinct possibility. Also, many hospitals, not only Ukraine, but other low resource centers, take care of not only civilians, but military. So there's a mix of civ-mil. And that's a very important component. We in the US tend to separate those. I think in other countries, there's much more of a mix where people are going to go to the closest medical facility, whether they're in military uniform, plain clothes, or innocent civilians caught in a crossfire, which puts the healthcare professionals at risk themselves. And also, they have to practice humanitarian neutrality. They may have to take care of soldiers on both sides of the conflict, let alone the civilians that are caught in the crossfire. So very difficult situation, but I think more likely, as you mentioned, is an industrial plant either being accidentally or intentionally bombed, particularly in these heavily industrial urban areas that we're seeing with urban conflict.
So some of the responses that we've gotten, and Amani, I know you're aggregating that stuff, so you can feel free to kind of read them out. Really harkens back to that austere environment, you know, scenario that we've talked about, which is a lack of equipment or no water or no electricity. One of the things we've learned, at least in the States, is that Mother Nature can put you back to the Stone Age in the blink of an eye. It doesn't take much. Earthquake, hurricane, tornado. And one of those things also damages, you know, in the scenario we just talked about, some type of industrial infrastructure where there's sea burn, like Fukushima. I think Fukushima is a great example of a complex disaster, a disaster made worse by another disaster. I think, you'd be hard pressed to respond to something like that. So we're not even talking about, at this point, maligned actors, violent non-state actors. We're just talking about nature and our reliance on an industry, chemical industry, nuclear industry, that could place us at risk. Once again, these casualties, those impacted, will be coming to civilian hospitals by civilian EMS, right? To the doors of emergency rooms of hospitals. And so, how do we conceptualize those threats over the horizon? And how do we make ourselves more resilient against those complex hazards? One comment was to get more protective equipment for medical providers, and the observation, which I think is pretty astute, is that not all filter masks are available in the general market, and that's something we found ourselves. So, anything you want to add to that, Tim, before we move on to the next question?
No, and at some point we've heard from colleagues in the Middle East and East Ukraine, East Europe. I know we have colleagues from Malaysia, Brazil, Canada. If you could talk maybe about your region that hasn't been mentioned. Is there a CBRN threat? Are you concerned? Is it more of a global issue? Is there something unique to your region of the world that makes it a setup or a concern for a CBRN event? Would really like to hear from others beyond the regions we've discussed, if possible, if you feel comfortable.
And in the meantime, I think we have a fourth question. If we can pose that question, that'd be great.
Second.
And Amani, I actually see questions number 1 through 3 on the
Yes,
poll.
I just launched.
Okay, I see it on my screen now. Great.
Great.
Yeah, this is a really good question. I would love for one of our colleagues who are attending to maybe raise their hand and give us some perspectives on what they've seen in terms of supporting countries that may find themselves in conflicts or austere environments with preparing for responding to CBRN. As comments from some of our colleagues have mentioned earlier, we have really a broad spectrum of individuals with unique experiences here that I'm sure we all benefit from hearing, like Huda's testimony. So does anyone have any best practices or things they've seen work in regions or countries that they've worked in or they're familiar with that increase CBRN capabilities for medical workers specifically? I like those two. I see a couple of great ones. Urgently providing materials and expertise on the ground. I've come away from my Ukraine experience being pessimistic about building a capacity during wartime or conflict time, but being optimistic that if you have the right people, it can be done. And I know that sounds like I'm talking out of both sides of my mouth, but it's very difficult to build a capacity or capability to respond to CBRN when there's a crisis going on. I think we're creating the blueprint for that, Tim. I mean, correct me if I'm wrong. I think that um, maybe Syria, but I haven't seen much data on that. I think this is the first documented time of CBRN capabilities being being developed during an active hot war since, quite possibly World War II, maybe in the civilian population specifically. But I would, I think that's research and a discussion we can have completely separately about how do you do this work effectively, given international regulations, given the potential for war crimes and all the kind of complexities that we've talked about, as well as competing. I think this is I want to bold, underscore, and italicize this, competing interests during a war, right? CBRN is not very high up in the priority list during the current war in Ukraine. I have to be honest with you. It is, humanitarian aid comes before that, and before that, it's lethal assistance and war fighting. And so, preparedness in a setting that there was no preparedness before, I think is very difficult. I think the key is to identify, regions that could be vulnerable to CBRN and get them prepared before conflict happens. But do you have anything to add on that, Tim?
No, I couldn't agree more. No, I think the globe is changing. We're really experiencing, for all intents and purposes, World War III by proxy. So I think the threat of CBRN is there. The actors that are involved, whether they're state actors or terrorists, may not be acting on their own soil, so they may be more apt to use chemical, biologic, or radiologic nefarious means to move their agenda. We're seeing countries now allying and taking sides that we haven't seen, quite frankly, since World War II. We see the North Koreans allying with the Russian military, and the North Koreans have used chemical weaponry in political assassinations in the past. So I think we're at a time where it's not about region or even countries. People can travel easily, and everywhere is a threat. We talk about low, middle income, austere countries. I think the more heavily industrialized nations are also very vulnerable. And to your point, Donnell, it is a priority in the budget, in the emphasis. CBRN usually goes down the list because it doesn't happen that often. But when it happens, it's disastrous and people are ill prepared. Then the politicians and leaders act. What we don't want is a sentinel event. We've had that in Syria. We had it in Tokyo in 1995. We've had it on individual political assassination attempts and successes by nefarious actors. I think there's enough information out there that we need to have the means, the attention. And as Krilo said at the beginning, we hope to never use this. We hope you don't have to face this. But as soon as you don't prepare for it, it will happen. And innocent victims will lose their lives. And it's something that is preventable if we know it's coming and the potential is there.
Yeah, and I think that, and we've learned this, and we're actually, I think we're evolving our approach to CBRN and how we communicate it with donor communities, humanitarian communities, and our government partners. Maybe you bring the E part of CBRN further up, right? And talk about burn and blast injuries, as our colleagues have talked about earlier. Because if you can prepare for, burn and blast injuries, a lot of the other CBRN is really agnostic, right? It's decon, it's assessment, it's triage. And so if you get a blank stare from people who are supposed to support you when you talk about CBRN, you talk about specifically, well, we need to be able to treat complex burn and blast injuries from a variety of etiologies, from radiological all the way to chemical, right? I think that's an interest that may get people's attention more so than talking about, these high consequence, low probability scenarios like, a virus being spread, right? Or some type of sarin gas attack. And so since CBRN is so broad in terms of its scope of topics, um, uh, choose the E part, the very last part, to bring the conversation out there. I think that's a good tactic. And I think that's the tactic we're going to be following in next year and thereafter, because to Tim's point, it is a low priority, and many people don't see it as something that's a concern in a conflict area. I put in the chat, I love the community of that kind of community of common practice or practice. Hopefully we can have discussions hereafter about how do we develop that, and really kind of coalesce around this topic and coming up, like you clearly see that Tim and I don't have the answers, right? This is why we're engaging you, right? But we didn't want to come here and kind of commiserate over the problem. So I like the way this discussion is going. And I would like to invite maybe one or two people just to kind of say some closing remarks before we get to our final closing remarks. If anyone has anything they want to add or say for the good of the collective here. If not, Tim, I will turn it over to you, my friend.
Well, a couple of closing remarks. First of all, thanks to everyone from over 25 countries that joined us. Your time is valuable. You have many things on your plate, and yet you volunteered to join this webinar. We hope to build a coalition. Certainly within Ukraine, we're proud of our Ukrainian colleagues and the wonderful work they're doing under very difficult circumstances, but this is also about reaching out globally to other areas of concern. If you find that CBRN training, CBRN awareness, CBRN equipment, those types of things need to be addressed in your region of the world, we're open to hearing about that. We're happy to help. We're happy to take materials we've developed through the Ukraine project, and as we said at the outset, make them culturally, language sensitive to the area of the world you're dealing with. As we've said several times, we hope these events don't happen again, but the risk is high, and people have access to recipes online and ways to make this happen. And we talk about low resource setting. Creating CBRN events can be a low resource type of nefarious act. So thank you for the time from the bottom of our hearts. We're here to help. We're here to share. We're here to collaborate. We don't want to reinvent something that one of you may have done a magnificent job putting together. We're happy to use your materials, of course, give you full credit. And any of the articles and slides that we put together, we want them to have access to you so you can also train in your area of the world. We hope that this topic doesn't become so frontline, but I'm concerned again with the way the world is going and how people are taking sides, that it's a greater risk than ever. But thanks for the time. I'll turn it back to Donnell for further closing comments.
Thank you, Tim. I'd like to actually turn over to our colleague from Ukraine, Kyrylo. Do you have any final words that you want to impart on our colleagues here before I close this out?
I think no. Thanks.
Excellent. So we do, I don't want to reiterate what Tim said, but we know your time is valuable, and we do appreciate you spending that valuable time with us. We think this is an important topic As I had mentioned before, we don't have the answers. We want to create, and I'll use a term from one of my colleagues, Shauna, communities of practice. And so perhaps this is a nascent effort into coalescing around this topic on how to protect low and middle income countries who may find themselves in humanitarian crises or conflict or war from the effects of CBRN. And if that's something that resonates with you, we'd love to hear from you after this. Reach out to us. Let us know if there's additional webinar topics that you may be interested in. Let us know if you want to engage in research and be a research partner with us. We're always looking at collaborating with colleagues from across the globe. It enriches us as a community and enriches us individually as researchers, as practitioners. And let us know if you have any ideas of how we can kind of create this community of practice. That's something that's I think very provocative in a good way, and we want to hear more about. I will, I'd love to hear Leah, Amani, Katie, our colleagues from HHI. Anything else that we may have missed, or any follow-up things that you want to impart on our colleagues before we let them go?
I have nothing to add. I just want to thank you, Donnell, and Tim, and Carilo for sharing with us your insights and letting us ponder on how we can take this work and expand it globally. I think we have left our audience with a lot to ponder on and see how we can effectively help the healthcare workers, the humanitarian workers, but also the civilians in low resource settings, particularly in Gaza and Lebanon, who are currently experiencing the war crimes. And with that, I want to also thank the audience for being here today. Thank you for participating. We hope to hear from you. As Donnell and Tim said, we're always happy to collaborate and see how we can expand our efforts. And I finally want to thank Amani for putting the logistics behind the webinar together. Thank you so much for all the work you have done.
Thank you. Thank you to our panelists and our attendees today. I put it in the chat. You can find the recording of this webinar on the HHI YouTube channel. If you have any questions for HHI or for the panelists, please email hhi@harvard.edu and we can direct you to the correct person if you would like to reach any of our panelists. Thank you so much, everyone.
Thank you all. This is till we see each other again. Hopefully, we'll see each other, and we'll look forward to our next webinar. Share it with your friends and colleagues as we create this kind of community of practice. We'll give you back the rest of your day. Be safe, take care, and we'll see you next time. Thank you, everybody.
Thank you so much.
Thank you.